I used to ask people on the first day, like, what do you want to go into? Now I only ask that on the last day.
Welcome back to PedsCrit. I'm Zach Hodges.
And I'm Al Shanklin.
And today we have a new interesting topic for you on PedsCrit, a little different than typical. Today we're interviewing two adult critical care clinicians.
Yes. In June of 2023, there was an article published in ATS Scholar titled Gender Disparities in Critical Care Procedure Training of Internal Medicine Residents, and I freaked out when I read it. I've thought about their research whenever I'm on service, and I was so excited to recruit these intensivists to talk with us.
Yes, it's a fascinating paper. The lead author is Dr. Emily Olson. She's a pulmonary and critical care medicine fellow at Northwestern University. She attended medical school at the University of Wisconsin and completed her internal medicine residency at the Mayo Clinic. In addition to her work on gender disparities in procedural training, Dr. Olson is interested in clinical feedback and transitions in medical education.
Yes, and the senior author is Dr. Lekshmi Santhosh. Dr. Santhosh is an associate professor of medicine in both the Division of Pulmonary Critical Care Medicine and the Division of Hospital Medicine at UCSF. She practices in the MICU, neuro ICU, on the internal medicine teaching wards, and in the pulmonary outpatient faculty practice. In addition to her clinical work, she serves as the curriculum APD for the internal medicine residency, and she's an associate program director of the Pulmonary and Critical Care Medicine Fellowship. We were absolutely thrilled to be able to sit down with both of them.
Yes, let's get right to the content.
Doctors Olson and Santhosh, thank you both so much for joining us today to talk about your paper. Let's start by having both of you tell us something about yourself and include something that you enjoy outside of medicine.
I can start. My name is Emily Olson. I am a second-year fellow at Northwestern University in Chicago after having done my internal medicine residency at Mayo Clinic in Rochester, Minnesota. I really love general pulmonology. I love teaching in the ICU. It's been a great fellowship experience. But outside of the hospital, I have been quite busy the past few months, and I have a 3-month-old daughter that has been keeping me up at night, and we have really loved seeing the world through her eyes.
Oh, well, congratulations. That is
Thank you.
awesome.
Love it. Congrats, Emily. I'm Lekshmi Santhosh. I'm an associate professor of pulmonary critical care medicine at the University of California, San Francisco, UCSF. And I, like Emily, have really loved being involved in medical education of trainees, fellows, and even faculty throughout my career. I work in the ICU. I also work in pulmonary clinic and on the general medicine wards and do a lot of med ed stuff in my roles as the associate program director of the medicine residency and the Pulm Critical Care Fellowship. All adults, mind you. So PICU scares me terribly, and I really admire you both. What I love to do outside of work, I have two daughters who are 5 and 6. Love hanging out with them and spending time with them. And I also love food and politics. So I'm a foodie. I love trying new restaurants, reading about new restaurants, recipes, cooking shows, and then also love political news, kind of a politics news junkie as well. Great to be here with you all today.
Yeah, thanks so much. Emily and Lakshmi, we're interested to know, how'd you get interested initially in gender disparities in medical training and medical education?
I think a lot of what sparked my interest was really the experience that I was having as a trainee going through the medical system. I would see nurses go up to my male colleagues and say, like, hey, doc, what's going on? Whereas I felt ignored from time to time. And I oftentimes had good discussions with my co-residents and now my co-fellows about, why are these interactions a little bit different for me as a woman in medicine comparatively to my male colleagues? And I think those discussions really sparked a lot of the projects that I ended up being involved with in residency and some of the conversations that I've had now as a fellow.
No, absolutely.
I also feel similarly passionate about gender equity work and gender equity research. And all of the research projects that I like to dive into, for me personally, have an advocacy aim. And so for me, it started exactly as Emily said, as an experiential noticing of differences, particularly in high stakes procedural environments such as the ICU. And I noticed it when I was a trainee. And interestingly, I noticed it from a different lens as an attending, where I noticed sometimes that there was a disconnect between confidence and competence. And
Mm-hmm.
sometimes that disconnect was gendered, and there was a little Dunning-Kruger effect at play. And so it was my experiential noticing from both sides as a trainee, as an attending, supervising, that wanted to delve deeper into this question with the advocacy lens of A, are there differences? Let's explore that. If there are differences, what can we do about that?
Oh, absolutely. Now, because a lot of our audience is early critical care fellows or early career pediatric critical care attendings, what advice would you two have for someone who's really looking to explore this niche in the PICU world? Are there things we should be reading, like basic texts we should be reading, things we should be sort of thinking about as we structure these projects?
What an interesting question. I would recommend not necessarily reading, but just taking a pause and thinking about the environment around you and looking more of a QI lens. How do we improve not only our learning environment, but also patient safety with procedures, and thinking about what are those interactions that we're having with our team members, and how do we improve those interactions to be more equitable among trainees, but also just allow us to have a more diverse workforce, because without those experiences, we're not going to be able to improve how we go about things.
I love that, Emily. I love that approaching this from a QI lens. That is such a great recommendation. In terms of foundational readings in gender equity research in medicine, I would consider myself a very novice in this area
Mm-hmm.
myself. I think I would still say I'm still learning and growing, and I have amazing mentors on gender equity work who have worked on this. And I think some of those that I'd like to shout out, both direct mentors as well as national thought leaders who we can learn from. The work of Dr. Reshma Jagsi. She is probably the foundational scholar of gender disparities in academic medicine. Definitely any article written by her. She's had countless New England Journal and JAMA articles on this topic. That's foundational reading. Articles by one of our UCSF senior women faculty, like Dr. Christina Mangurian, Dr. Urmimala Sarkar, as two who come to mind who've done a lot of pioneering research on women in academic medicine. And then for a pediatric shout out, Dr. Nancy Spector, who runs the ELAM program, Executive Leadership in Academic Medicine, is another sort of pioneer in this space. So if you read works by any of those people that I've mentioned, that's a great foundation to gender equity research in academic medicine. And I still learn so much from all of those individuals and admire them and hope to be like them someday.
Fantastic recommendations. We're excited to get to your paper and talk about, extensions, what we can do to apply that in our local practice. But something we do for every episode is ask about conflicts of interest. So any conflicts of interest to disclose?
No.
Nope.
Sounds great.
All right. So, two quick disclaimers before we get started. The first is that when Zach and I talk about procedures in pediatric critical care, we know that it's a little bit different than the adult critical care world, in that these procedures are sometimes technically more difficult if the vessel is smaller and maybe a little bit more rare in children. Because of that, we do sometimes do these procedures with residents, but it's less of a right and more of a lucky thing that happens to a resident, where you're in a situation that's slowing the procedure down, and offering it as a shared procedure makes things more safe and not less safe for the patient. The second disclaimer that I want to hit here is that if we think about sex as biologic and gender as a social construct, this paper uses a binary and does not cross the full spectrum. And so it's not a complete representation of gender experiences or disparities.
Totally agree.
Yes.
Well said.
Thank you.
All right. So to get right into today's discussion, we're excited to talk about your paper entitled Gender Disparities in Critical Care Procedure Training of Internal Medicine Residents. Dr. Olson, will you tell us, what were y'all seeking out to accomplish in this study?
Our initial thought process was really founded by Dr. Santhosh, Dr. Murray, and Dr. Desjardins over at UCSF, of trying to understand what was the experience that residents in internal medicine were facing with procedural rotations. And it came out of ongoing discussions among residents of what is that experience? Why are we perhaps getting fewer central lines in the ICU, but our procedure rotation is going so smoothly? And so we really sought to try to understand what are the numbers behind that emotional experience and sort of perception of what's going on in the day to day.
That's exactly right. I think the cool part about the study is not only is it mixed methods, but it's also multi-institutional. And so we really approach this research question quantitatively and qualitatively, and at UCSF and Mayo. And we felt like that provided much richer insights than if we had had just a quantitative approach or just a qualitative approach or just UCSF or just Mayo. And our strength is really in the diversity of our team.
Mm-hmm. Absolutely. Would you say when you say mixed methods, you mean we have these numbers, now we're going to really work with focus groups and do really good qualitative analysis to explain them?
Yeah, absolutely. We chose to do an exploratory sequential design in terms of that mixed methods, and we tried to identify that quantitative data first at both institutions before diving into the qualitative. And so, really, our focus groups were developed, our scripts were developed based on what we were seeing on the quantitative side.
Nice.
And the other thing about our qualitative research is that it was really grounded in the prior literature on this space. For example, the surgical literature, as you can imagine, has a lot of available data and experience and research on genders and procedures in the surgical world. And so we didn't want to just kind of make up questions. We really wanted to do a rigorous process grounded in the current literature that was applicable to our sample population.
Mm-hmm.
Will you tell us more about how you structured your focus groups? If I'm reading the paper, I recall maybe separated like between male and female. And will you tell us maybe how maybe having people together in the same room maybe helped or added to that discussion?
We really tried to have gender congruent focus groups because we wanted to get shared thinking, sort of like a think aloud, and try to capture the culture at each institution felt by male residents comparatively to female residents. And we felt that a focus group was a little bit better than a one-on-one interview because oftentimes you can spur some of that discussion of thinking across one another. And the other benefit is that by having so many people in a room is that we were able to have first year residents and third year residents bouncing off their different experiences, knowing that an intern's experience with procedures is going to be much different than somebody who's a little bit further along in their training.
That's right. I think the beauty of the focus group, rather than the other choice we could have made, is a structured one-on-one interview. But the beauty of the focus group is that you see these ideas bounce off each other and you see people say, that happened to me too. That was exactly my experience. Or, oh, I didn't experience that at all. This was my different experience. And so you actually capture richer data qualitatively in this research question with a focus group rather than a one-on-one structured interview. We debated a lot about the gender congruent focus groups versus a mixed gender focus group. And again, we looked to the prior literature, and prior literature as well as experiential data showed that people felt there was sort of a safer space to discuss some of these thorny, complicated, even taboo type of questions around this complicated topic. And we really wanted to gather as rich experiential data as we could with people feeling like they were in a safe space and that other folks in the focus group might share their experience. So we designed it purposely that way to kind of maximize the richness of our data gathering and to give voice and safety to the opinions.
Oh, nice. I love that you did what my mentors are always lightly suggesting I do and base those decisions on have a reference to support all of your decisions. Let's talk about your results. So what did your quantitative analysis find?
We saw that there was a difference between the experiences people were having on IC rotations comparatively to a structured procedure rotation at one institution, but not the other. And so you might ask, okay, what exactly does that mean? And so what we analyzed was how many procedures are residents obtaining when they're on a structured 2-week rotation where we're doing procedures on the general wards. It's first come, first serve as to the rotation of who's getting that procedure. Comparatively in the ICU, procedures fall to whichever resident is taking care of that patient or whoever speaks up. So we counted, based on notes, the number of quote unquote ICU procedures, things like central lines or A lines. There was a difference between genders in the ICU procedures, but only at one of the institutions. And so I think this brought up a lot of questions on our end of why exactly are we seeing something different in a quantitative way between the two institutions.
Wow. So you pulled procedure notes, split them into male or female, and found that one of the ICUs, more male residents were getting those procedures.
Absolutely. And we asked ourselves, was this based on time on rotation? Because some people do electives and have more time available to do those central lines. But no, we factored that in, and no difference based on time on rotation either.
Okay.
I thought it was really fascinating how y'all compared the ICU procedures versus the procedures on the hospital ward team that was controlled. And maybe for a couple of clarifying questions, I'm just imagining on the structured procedure rotation, was this like a resident and an attending who basically their job during the day was to go around and do the procedures needed to be done so you could control those details?
You bet. So ironically, both of our institutions had this model where if somebody on the general floor needs, for example, a paracentesis, they call the procedure team, and it's Lekshmi, correct me if I'm wrong, but at Mayo it was 2 residents and 1 attending, and you're really going around the hospital doing all the procedures, and it flip-flops back and forth. And I think that was the same scenario as UCSF.
Yeah, it's a structured proceduralist team for the hospital medicine wards. It's usually a couple of interns, actually, and a faculty member. And again, it's doing the hospital medicine procedures, so not central lines or arterial lines or intubations, but rather the thoras and paras and lumbar punctures, things like that. And I think that one of the interesting things that came out in our discussion, right, both in the qualitative focus group and in our discussion section where we kind of hypothesize about these differences, is that there's this concept of self-advocacy when you're in an unstructured training environment, that people might feel that they have to, quote, fight to get that procedure and advocate for themselves to get that scarce resource of a central line, which I know from the literature is even more scarce in your context in PICU. So we'll tell you about our paper, but I'm also curious to learn from you all how this paper resonated with you all as PICU clinicians and how things are similar or different from the adult world where Emily and I practice.
Oh, yes. Thank you for flipping this back to PICU. I have thought about this paper twice a week on service since I read it because, as I mentioned, these procedures are so valuable for some learners. The situation where you can comfortably get the chance to do them is rare. You absolutely need to put yourself out there to get them. And so while I think that at least at Children's National Hospital, we probably don't have the volume to do a study like this with significant results, I'm positive that the bias is magnified because they're rare and you have to kind of be in a unique scenario and you have to really advocate to get the opportunity to do them, you know? And on top of that, there's, the fellow experience and who's considered to be able to do what and who's rolling up their sleeves for the peri-arrest patients earliest and fellowship and things like that. But that is a little more vague. Which residents are getting the procedures and are we offering more procedures to men is really the thing that stuck with me.
And from my perspective, I was thankful to have a chance to chat with Alice about this beforehand. I haven't done any adult medicine since I was a 4th-year med student, so I certainly am ignorant to the comings and goings in adult medicine. But speaking with ER residents who rotate with us in the PICU and colleagues who are in adult medicine, the risk tolerance in pediatrics is just so small.
Yeah.
When I hear about our medical trainees who are in adult medicine doing procedures without immediate supervision, that doesn't happen in our center, and I suspect it doesn't happen in many centers. If a resident were to do a procedure in our pediatric ICU, they would have an ICU fellow scrubbed in and immediately available to intervene, and they'd have an attending at the foot of the bed watching every move. And it's an incredibly monitored and supervised scenario. And then the kids that end up in the PICU, similar to, I imagine, the adults that end up in the ICU, those are the ones that are most medically complex. Those are the kids, right, the patients who have had prior procedures. That IJ is not going to be as plump and a nice target as it was at one time. So the procedures are inherently more complicated, I think, because the patients are smaller. There might be some urgency to the procedures, and the result is, unfortunately, residents don't get the opportunity. And And it's also reflected in like the national leadership in the area. So, those that govern pediatric residency training, they're de-emphasizing procedural competency. So I only see it as something that feeds forward on itself, where residents will continue to get less and less procedures. And if there are disparities, and we think there probably are in pediatrics, just like in your study, it'll probably only become more significant.
Yeah. You guys bring up so many great points. And I think this is something I've been talking a lot about with my co-fellows of how do we feel comfortable doing those low volume, higher risk procedures? And it's that low volume that is an ongoing challenge in medical education as a whole, because we want to be able to do what's best for the patient in terms of patient safety and make sure everybody on the team feels like they're part of that care. But also know that if I'm by myself in the ICU when I'm an attending, I want to be able to do that procedure and do it confidently and be able to lead a team. And it's really that balance of how do we train in a way without creating disparities for these low volume procedures, as you guys mentioned, and especially in the PICU.
Yeah, absolutely. So you have these numbers. That gender disparity in ICU procedures is a real hot potato. And now you're trying to put together, do these deep interviews and figure out why. What did your qualitative analysis find?
I absolutely loved our qualitative analysis because I think the data was so rich, and reading through these conversations, it really helped us understand the experience that residents are feeling from both a male and female perspective. And so we performed a thematic analysis, as Lekshmi said, guided by grounded theory. And there's 3 major themes that came out of our analysis. The first was this idea of self-identity, really as a proceduralist. So trying to understand, do male residents feel a little bit more, hey, I'm a proceduralist, I can go in, get this procedure done, regardless of how many I've done in the past. The other theme that I think was one that spoke to me is an idea about procedural self-advocacy. It's this concept that, if you're not going to speak up, you're probably not going to be able to do that procedure, or at least that's how our residents felt. And women residents in particular felt like they had to advocate for themselves a little bit harder compared to their male colleagues. And then the third theme that really shone through was this concept of team dynamics in how procedures got distributed among the team. Knowing that an ICU team, as I'm sure it is in pediatrics, is not just the intern, the resident, the fellow, the attending, but it's also the patient and their family. It's also the nurses at the bedside. And that giant team, in trying to identify who's going to be the one to get that procedure done based on how fast it needs to get done, based on patient complexity, that is going to also impact how residents get the procedures. Knowing that team dynamics and gender equity is a complicated concept and complicated discussion that we have no time to actually dive in today. Yeah.
Totally. Emily so nicely highlighted the main themes. And if you go to the paper, the quotes are simultaneously enlightening and heartbreaking. I love qualitative analysis, and I think it's such an important research methodology to explore these questions of, we found the what, but what's the why and the how? What are kind of possible mechanisms to account for these differences? And that's what these quotes show you. These concepts of identity, advocacy, and team dynamics shine through in the quotes, where people talk about how I never thought of myself as a proceduralist, or the person would always assume that a different team member would get the first dibs on this procedure, and I had to really assert myself. People talking about backlash, perhaps, when they advocated too hard for themselves. And all of these rich quotes, there's one page of the paper that you could read. It's that quote table where it talks about these rich quotes, which I think have resonated with a lot of people who have read our paper.
Absolutely. If you're an intensivist, in my opinion, you can't not see yourselves or see your program in these quotes. It's really impactful.
Out of curiosity, self-identity, self-advocacy, it certainly is core to getting procedures in these unstructured environments like the ICU. I'm curious, in your 2 cohorts, what was the breakdown of men versus women who either desired to go into procedurally heavy fields and ones that actually ended up doing that?
So, interestingly enough, the institution that had the disparity in ICU procedures actually had more residents graduate and go into procedural specialties such as cardiology and pulmonary and critical care. What's interesting in our focus groups, however, is that we had a pretty broad range of people who went into procedural specialties as well as people who ended up in primary care joining this conversation. And I think it just made what that conversation was about all that much richer, because we want to be able to have equitable access to procedures regardless of what you're going into at the end of your residency.
And after thinking about your quantitative and qualitative analysis, do you have any readily available points that we can help trainees with, their self-identity or their advocacy, or how to improve team dynamics to make sure that procedures are equitably distributed?
Or things that we could do as team leaders and educators?
This project has changed how I practice as a fellow. Now leading the team, trying to understand who is going to do central lines and who is quote unquote signed off. I've really taken a pause at the beginning of my week and really asked people, where are you on procedures? And also made myself available, not just like, hey, call me if you need me, but I want to be there for every line, regardless of if you're signed off or if you're not, to be able to create that learning environment so that people feel comfortable, regardless of how many they've done previously. Because even if you've done 5, it could be that next one that makes you regret all procedures in the future and feel scared. And I don't ever want people to feel that way.
Oh, interesting.
I love this question, Zach. And I think this gets back to advocacy, kind of what can we do to change things? And that was immediately where my mind popped to. And I have also changed my practice since. One thing is that at the beginning of the week, I too, as an attending, meet with each trainee individually, one-on-one, to get a sense of their learning goals, including procedures where they're at, but also their holistic learning goals as well. And I used to ask people on the first day, like, what do you want to go into? And now I only ask that on the last day, actually, because I feel like it might change their self-identity. If you tell an ICU attending on the first day, I want to go into cardiology or pulmonary critical care, and somebody says, I'm not sure, I'm deciding between pulmonary and hospital medicine and ID, as I was when I was a resident, I wonder if that could subconsciously or consciously also impact procedural allocation. So now I don't ask people's career goals. I know a lot of the residents pretty well, so I know a lot of their career goals, but I don't ask them that until the last day, because I don't want them to have almost that stereotype threat in the beginning of the rotation. I say explicitly to the whole team, procedural allocation, these are scares. We want to make sure that you're safe and supervised. A fellow and or attending is going to be in the room for all procedures, because these are the sickest patients in the hospital we want to take care. And then every time a procedural opportunity comes up, instead of the old school default method of whoever wants to can do it, or if it's your patient, you can do it, we have a little pause and conversation each time to say, hey, who is the primary resident on this patient? And or who has different learning goals, who needs more procedures, who wants more procedures. So we actually have a conversation about it each time, rather than immediately defaulting to the resident whose patient it is. And sometimes the resident whose patient it is actually wants to go into, I had a resident do this, wants to go into telemedicine and virtual primary care. And awesome. Forcing them to do a central line, I don't think is also necessarily good for the patient or their learning goals. That's the flip side of it too. And, Dr. Deister, one of our graduating fellows, and I wrote another paper about individualized learning plans for procedural competency, because at the end of the day, we also want to achieve individuals' learning goals. And in an environment of procedural scarcity and low volume, everybody should have a basic understanding of procedures and be able to be involved and participate in procedures. But not every resident necessarily, to your point, has to do 5 procedures if they're going to become an endocrinologist. Not necessarily. And so as there are fewer lines, we should think more equitably about allocating procedures and be mindful of not worsening existing disparities in an environment of low volumes. There's so many factors, but those are some of the concrete tips that I share that I have changed my practice with since the study came out.
Oh, nice. So, two themes I'm hearing. One, in response to this disparity, you increase supervision across the board. You're like, if this is where the disparity is coming from, someone being willing to do a line without supervision will just supervise everyone, improve the care we provide to our patients. And then the second theme that I'm hearing is that there's an interaction with the way that you identify the experiences you've had and the way that you plan your career and select a subspecialty. I'd like to dive into that more. What's going on in adult Pulm Crit in terms of gender disparities, and how do you see that start during residency?
Excellent segue into a time-old question of, are people seeing themselves represented in the career that they're interested in going into? This was a big question of mine as I was starting to figure out what I wanted to do with my life, is could I see myself in this role? I would say there are fewer women in Pulm Crit comparatively to medicine as a whole. There's about 30% of fellows in adult pulmonary and critical care medicine that are women. Comparatively, about 45 to 50% of residents in internal medicine are women. And so there is that gender disparity at baseline, and it does get smaller as you get into leadership. So there are fewer women who are program directors in pulmonary critical care medicine comparatively to even division chiefs or Department of Medicine chairs. And we see this at a national level as well with our societies in terms of representation among boards, councils, as well as awards that people are receiving.
That's exactly right. I had been very interested in this question of where does the quote leaky pipeline occur, specifically in pulmonary and critical care medicine, both by gender as well as race, ethnicity. And Dr. Jen Babbitt and I did a study on this very topic, gender and racial ethnic disparities in pulm critical care in the pipeline. And exactly as you're alluding to, Alice, really the big kind of opportunity for intervention or the big drop-off is at that resident to applicant level. So that's where kind of the disparities get heightened. Really what that comes down to is three things: mentorship, exposure, and again, that concept of self-identify. Do I see myself in this pathway, which relates to both mentorship and exposure? So what we can do to improve recruitment and retention of women and minoritized individuals in our pipeline is to really improve systematically our mentorship opportunities and also our opportunities to expose people to our career and both the clinical aspects of our career as well as the scholarly and research aspects of our career.
I appreciate that perspective, and especially the fact that when we talk about gender, it's a sliver of the problem that's much deeper.
Well, Dr. Emily Olson, Dr. Lekshmi Santhosh, we have enjoyed so much speaking with you today on this very important topic. As we move towards the end of today's conversation, we'd like to just open it up to you one last time, perhaps for other applications of what you see from your study or points that you'd like to reinforce.
Well, first off, thank you so much for having us. And I've learned from you both on what is going on in the pediatric critical care world as well. In terms of where we can go from here, I'd really encourage all our listeners to pause and think about what's going on at their institution, but also just what's going on in their team today. And where can we take a pause and say, how do we get people involved in procedures so that it's more equitable? So that people don't have to feel like they are self-advocating to the point that they are exhausted. And I hope that it'll improve not only procedural competency, procedural experience, but also the future of critical care and where people are going.
Beautifully said, Emily. I'd like to second that thanks to Alice and Zach for having us on the podcast. I've learned a lot from you all, and I always learn from Emily, as I did in the study. And again, a shout out to Dr. Jackie Desjardins, who couldn't make it today, but who's a cardiology fellow, soon to be faculty at UCSF, who was, of course, integrally involved in the study too. My take homes are slightly different if you're a trainee who's a listener or a leader who's a listener. If you're a trainee who's a listener, I hope that reading this paper and listening to this podcast provided some measure of validation to your experiences. Sometimes when you have some experiences where you are feeling like I had to kind of fight for that procedure. I had to self-advocate, or I felt like that treatment was different because of my gender. I hope that reading these quotes will help you feel that you are not alone and that your feelings are valid and that this is a structural and systemic issue. Things you can do about it concretely is one, believe that you belong there and that you are the owner of your own identity and you can do what you want to do. And second, knowing that that self-advocacy is important and knowing that you can do things as a trainee to try to even promote more equitable and deliberate allocation of procedures. If your leader's not doing it, I encourage you to lead up. If your team leader's not doing it, I encourage you to lead up to say, hey, could we think of a better way to divide who's on for procedures each day, or could we talk about it each time? Things like that, a pre-brief or a pre-meet, or bringing it up when it comes out. So hopefully you have some more tools to do that self-advocacy. If you're listening and you're a fellow, a faculty member, or an educational leader, we hope that this opened your eyes to a problem that maybe you didn't know much about, or one that you knew about that you didn't know how to fix. Some of these gender equity issues can feel monumental, even insurmountable, when you're having a bad day looking at the state of the world. I hope that this article and podcast provided some concrete tips on how you can change that local learning environment by providing a deliberate pre-brief, by being more structured and deliberate in how you allocate procedures, and how knowing that mentoring and exposure are key to individuals' self-identities and self-perceptions.
Well, thank you both so much. I personally am going to steal your ask what procedures do you want at the beginning of the week and what you're going into at the end of the week. But we appreciate the time. Thank you for joining us.
Thanks so much for having us.
And thank you for listening to this episode of Pete's Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Pete's Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Pete's Crit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening. I'm just gonna let this siren pass.